My name is Hugh, if you haven't met me already. Yes, I have. I'm a Global Coverage Advisor. I've been working with ACF since 2010 in various roles, but now I am a Global Coverage Advisor, and I have been for nearly 3 years now. So what I do is run coverage assessments around the network. I'll talk about what that is and what that means in a minute. I work with the nutrition team here, and I have been part of Alex's team since she arrived, and before that with the operations team. So yes, just going to talk a little bit about some experiences and learning in the last 6 months or so that I've had, specifically from 2 surveys that I've run. One in Cameroon before Christmas and one in Bangladesh a couple of weeks ago. So I'm going to talk about that, and I'm going to try and capture some specific learnings from those experiences that I had. 40 minutes is not long enough to go through the methodology, the SQUEAK, or the coverage assessment methodologies. So I'm not only going to try to do that. I'll give you a very quick introduction and just focus on the little learnings that I picked up from that experience. So, or from these experiences. So just quickly look at coverage of CMAN. What, why, and how. So what is it? Why do we measure it? And how do we measure it? Just some very quick snapshot. Quick overview of the Cameroon assessment, which was a national coverage survey across 4 regions. And the Bangladesh assessment, which was a follow-up SQUEAK assessment in 2 districts, or 2 upsillas, if you're going to be using Bangla terminology. So, and then some various tips and learnings from this experience. So as an introduction, there will be hopefully lots of opportunities in the future to learn more about these topics, or more documents you can read if you want to, if you have time. But there we go. Let's push on. I'm pretty sure most of you have learned a little bit about community-based management of acute malnutrition, and where it fits within emergency programming, emergency nutrition intervention programming. But essentially, and hopefully Alexandra will be doing a nutrition series periodically. She does a nutrition series, a really good nutrition series, which talks through what CMAN is and how it's implemented. But essentially, it's the treatment of acute malnutrition in children in different contexts. It's the yellow boxes highlighted here. So it includes treatment of severe acute malnutrition, or SAN, in the community, so outpatient treatment, and in stabilisation centres or hospitals with inpatient treatment. It also includes the treatment of MAM children, so moderately acutely malnourished children, and this is done through targeted supplementary feeding programs. Blanket supplementary feeding programs also take place in emergencies. These essentially mean that any carer with a child under a certain age, so normally under 2, they automatically get a ration of food. But the targeted supplementary feeding for both severe and moderate acute malnutrition is basically when a child who falls into the admission criteria of the program is admitted and is then monitored over time and fed nutritional food in order to improve their health. So that's a really quick introduction. If you didn't know about CMAN, or community-based management of acute malnutrition, in a nutshell. So if you have any more questions about that, I can answer. But just to move on, and I just want to talk very briefly about why community-based management of acute malnutrition is called C, or has the C at the beginning, the community element. because it's really important to understand, just in terms of understanding the program and the modality of the programs, but also to understand a little bit about why coverage surveys that I complete are kind of important for addressing the kind of core components of these programs. So treatment is, needless to say, well, sometimes you do need to say it, but treatment is designed to take place in the community. So this is for the outreach component of CNAM. As you know, RUTF, or ready-to-use therapeutic food, plumpy nut is the better known term that we are very familiar with, is designed to be used in the community by carers. So it's a really, it's a very useful product. It's a miracle product that enabled treatment to happen in children's homes rather than in the health centre in a kind of controlled environment. And so very much put treatment in the community. The second point to add is that treatment is likely to be more successful if children are admitted early. So this is one of the kind of core principles of CNAM. Children need to come into the program early before they get extremely malnourished, or before they get malnutrition with complications, or SAM with complications, because this then leads to, or this can lead to very long lengths of stay and complications, and greater chances of morbidity or developing additional diseases, or of mortality as well. So this is a really important thing to add. Care should only last as long as needed as well. So whereas I emphasise obviously that treatment happens in the community, at the homes of the carers, at the homes of the children, they still need to come back to the health centre every week for a checkup, or every 2 weeks for MAM treatment. So these journeys that they're making need to be limited, because if it goes on for a very long time, if treatment takes months and months and months, then that can lead to a bad impression in the community. That can lead to negative perceptions. And also, really importantly, is the success of treatment and the quality of care in the health facility have a really strong influence on the perception of the programme in the community. So, if the health centre staff are very rude or very unwelcoming for the carers who are coming in, then this can lead to a very negative perception of the community, and negative perceptions can spread, and therefore people won't come to the programme. So these sorts of things, like this, having a very strong programme in the health facilities to start off with, where there are competent staff who know very clearly that the process of treatment is really, really important. And that's really what ACF has specialised in over the years. We've pioneered, and we were one of the organisations that pioneered treatment with RUTF, with plumpy nuts. And we are the kind of core people who train teams on how to deliver effective treatment in Bangladesh, amongst hundreds of NGOs that are coming to Bangladesh and providing life-saving support for the refugee communities. It's ACF who does the core training on treatment of acute malnutrition, both inpatient and outpatient. So we are the absolute experts on that. So that's just a kind of quick overview of what the kind of core principles behind this treatment method are. And that's the community in rural Cameroon. But the other things to add, just in really small writings here, just to make it difficult for you, are that access and coverage are really pivotal to the success of the programme. So because it's so community-based, it's obviously great that treatment can happen in communities, but the communities have got to come, or the carers have got to come with the children to the treatment centre to get their treatment. And so ensuring that there's really easy access, or as easy as possible, and that the coverage of the programme, as in the proportion of children who are able to access treatment is as high as possible is really important. And without these things, the program, like a CMAN program, will be missing a vital component of its kind of end mission of reaching all children in the community. So those are the kind of things that I look into as a coverage expert or a global coverage advisor, and the things I have always in my mind when I'm meeting with people and I'm meeting with the health centre staff and with the communities, just to try to understand, okay, what's going on in terms of coverage. So, is that clear so far, everybody? I'm trying to take out the technical jargon as much as possible, but essentially that's what we're doing. So, coverage is, what is a coverage survey? So I'm going to kind of quickly gloss over this again and move on to the results, but just quickly, coverage surveys, as you may have guessed, measure the coverage of CMAN treatment programs. What is coverage? Coverage is the percentage of acutely malnourished children in a district who are actively in the CMAN program at the time of the survey. Okay, so it's, if there are 100 acutely malnourished children in a health district, then we're trying to work out how many of them are accessing treatment, and if it's 40%, then 40 out of 100 or 4 out of 10 children in the health district are accessing treatment. So what we're trying to do really is just to get that percentage or get that rough range of percentage, but we're also trying to get the really important qualitative information. So the information which can tell us if these children are in the health district and are not accessing treatment, why aren't they? And this is really kind of the most important, well, one of the most important aspects of delivering an effective programs, reaching all those who are eligible for treatment. So that's what we set out to do with these surveys. We're looking at what these preventative factors are. We're looking at community perceptions about the CMAN program, what's working well and what's working better, what could work better. And in many cases, positive messages are coming through. People like the program, people like the product is visibly working on their children, and it's good information that's coming through. But in many cases, we encounter barriers, what we call barriers to treatment, or barriers to access. And we'll have a look at some of those barriers in context in a minute. Okay, so that's a coverage survey. There are a couple of different methods that we use. Here are some acronyms that I won't ask you to remember now. SQUEAK is like the central and most commonly known method. It's best used for a district level, quite a small or low level coverage assessment, and it stands for semi-quantitative evaluation of access and coverage. SLEEK is a more rapid version that we can use to do a coverage survey across a much wider area. So it stands for a simplified LQAS evaluation of access and coverage. So again, it's pointless jargon and complicated sounding acronyms for what is actually quite a simple methodology. I can do it. So those are the two main ones. However, also in that kind of family of assessments, there's something called a community assessment, which essentially is asking, okay, what are the community perceptions of malnutrition? What are the community perceptions of the program? It's like doing a huge qualitative investigation, lots of focus group discussions, without actually coming up with a coverage number. But it brings you lots of information which can be used to improve the program. And a bottleneck analysis is a form of looking at kind of key monitoring data that comes from programs to try to identify where there are bottlenecks in service delivery.
Just a quick question. So obviously ideal coverage is like 100%, but what's considered good coverage in a programme?
Great question. It's almost like I planted it. But I didn't. But anyway. Thanks. That's a really good question. So yeah, for treatment of acute malnutrition in rural contexts, so we look at different contexts, specifically in rural contexts. Acceptable coverage is considered acceptable if it's greater than 50%. So 5 out of every 10 children are accessing treatment in a very rural area, then that is good. If it's higher, brilliant, but it's rarely higher than that, in all honesty. It's a very, as we'll see later, there are so many different reasons why carers won't come to the treatment centre. That it kind of barriers for us, and so yeah. In urban contexts where the distances are much shorter between homes and health centres, the standard is 70%. So 7 out of every 10, if they can come for treatment, then we're doing well. In camps, in refugee camps, where everything's nicely organised, where every single child, every single family is registered, and they're checked very regularly. Their acute malnutrition status is checked very regularly. The standard is 90%. So, yeah. Okay. So just to move on, we're going to very quickly look at Cameroon, the bane of my life, for 2018. So I'm sure many of you who are here will know. It was a kind of ongoing joke throughout the year as to when I would actually be going to Cameroon. It was a contract with UNICEF Cameroon. They contracted me through something called the long-term agreement, or a long-term agreement that we have with UNICEF to provide expert nutrition advice. It's a really simplistic explanation, but we had an agreement with them basically. And then these are all, that was the donor, KfW, the German Development Bank, and it was done in partnership with the Cameroonian government and many other people that I won't go into now. But it was what they were asking for was for support from me to do a coverage survey of SAM treatment across the 4 priority regions of Cameroon. So they are the ones, I don't know if you can see here, but they are extreme north, Adamawa and Est, on the kind of right-hand side of Cameroon. I don't know, maybe if you don't know where Cameroon is, that's Nigeria there, that's CAR, Central African Republic on the right, and then at the top on the right is Chad. So it goes from a very kind of tropical rainforest, very kind of green, humid, to right up to the north, a very hot and dusty and harsh environment. So those are the 4 regions. It's a massive area, so I had to put my thinking cap on as to how we can actually do a survey in the time and with the resources available. But there are the 4 regions highlighted, and in the 4 regions there's a population of about 9 million, and there were 68 health districts across, including all of those that are coloured up there. So there was a lot of health districts. Typically, I'm used to doing surveys in 1 district or maybe 2 districts maximum at a time. So this was a new challenge for me. And we had about 3 weeks to do it in, and that was the data collection time. So I had to be a bit innovative with the methodology. So I decided, or I proposed to the team in Cameroon that we would focus on 12 sample districts. So 4 in extreme north and north, the 2 at the top because they've got the biggest populations, and then 2 in each of the Adamawa and Est at the bottom. So I decided on what I proposed, we would do a sleep survey in each of these districts in order to get a really rapid impression of what coverage was like in those areas.
Can I ask you, what's the capital of Cameroon?
Well, there are 2 capitals. Catherine. They are, well, officially, Yaoundé, here at the bottom, is the political capital. And then Douala, here just on the coast, is the economic capital.
So did you say most of the population's in the north?
Well, no, these are the priority regions. So
okay, sorry.
there is a big part of the population here, but we weren't interested in that.
Right.
They are actually only implementing CMA in the country in those 4 regions,
cool.
I think. Although all of the civil conflict that's been flaring up in Cameroon over the last year or so has been taking place around here, so southwest and northwest. Which are the 2 traditional kind of English-speaking regions. Cameroon is one of the only countries in the world which, aside from Canada, I think, which has French and English as the official languages. But to cut a long story short, there's been a big fight recently between those in the English-speaking regions who want independence from the French-speaking regions, which has caused a whole separate, well, it's caused essentially close to a civil war. So. But I won't go into that now. I wasn't really conscious of any of this happening. Well, it wasn't affecting me in Yaoundé when I was doing the preparations, so didn't really have to worry too much about that. But in years to come, it might be. So yes.
Thanks.
So what I proposed was to do 12 sleek surveys across those 12 districts, the ones that are highlighted there, the darker ones there. I won't go into how I selected them now, because we haven't got time. But suffice to say that they kind of represented a range of contexts. So some had good performance data, some had weaker performance data, and so on. But we had a big team, the biggest team by far that I've ever had to train. So we had about close to 90. It was 72 in total. So it's a data collection team of 72 with 18 kind of divided into 18 teams, and 12 days of data collection. The good thing about Sleep, though, is that the data collection process is quite straightforward. Essentially, what a team does, it goes to a village and it then tries to find every single acute malnourished case in that village by using various methods, sometimes by going door to door, sometimes by using images and photographs and packets of plumping up to try to find children in the program already. And they then collect data from each of the carers that they meet. So they did this across something like 180 villages in total, across the 12 areas, and collected lots of data. They did this using Kobo. So for those of you who know it well, Kobo is, or maybe don't know it, Kobo is a software that can be installed on smartphones and on tablets, which enables very quick and simple questionnaires to be filled in to collect kind of systematic quantitative data, and then it can be uploaded to a database and analysed and pulled apart in a very quick and simple way, or quite simple. So yeah, Kobo was a lifesaver in Cameroon. So just a couple of images, sorry they're a bit small, but training, here we are in the training room. The training room is in Yaoundé, which is one of the big, the kind of capital town in one of the regions, with all 80 trainees, very diligent I should say. They were mostly students actually, so Cameroonian students, all studying kind of nutrition or health focused degrees. But they were really good. I was really impressed at their kind of level of dedication and willingness. And obviously they were being paid for it as well, so that was an added motivation for them. So we did training and a bit of testing on children in the training centre as well, so making sure that everybody was able to measure a MUAC accurately. Does everyone know what a MUAC tape is? Mostly, maybe not. So an outtape is a tape which we can use. I think you didn't bring one up, but it's a tape that can be used to measure the circumference of a child's middle upper arm in order to determine if they are acutely malnourished and what severity of the malnutrition is. So she has one there. It's in black and white, so it's difficult to see. But that will fall into the nutrition series, hopefully. And then we went into communities everywhere. I managed to do some supervision in 2 of the regions. The security situation was a little bit dodgy in certain areas, so I didn't go all over the area. The extreme north, in particular, was a region which had been affected quite a lot by Boko Haram coming over the border into Cameroon. And I did actually go there in May last year to the extreme north, but UNICEF went there this time, so I didn't argue with them. And then actually on the border with the Central African Republic as well, it was a bit dodgy because there were quite frequent raids by cattle ranchers and people coming over from CAR to steal things, so I had to avoid that border. But I got to see some nice parts of the country. But what were the results then? Just quickly, let's have a look at the results. What we tried to do, here are the 12 regions: extreme north, north, and Adamawa and Est. So that's the furthest north and then middle. The way it works with sleep surveys, that instead of getting an estimate of coverage, you classify coverage in a range, so on a kind of 3-tier range. And so essentially, what this shows is that in 2 of the districts, we found very, very low coverage. In most of the districts, we found kind of moderate coverage. And moderate coverage we classified as being between 20 and 50%. So anything below 20% was extremely low. Anything from 20 to 50 was moderate, and then anything above 50%, as I mentioned, not a terrible, a kind of acceptable level of coverage in a rural district was considered high. And we found, there was one classified as high coverage district, and the rest were kind of 20 to 50. But overall, across the 12 regions, or across the 12 districts, we found the coverage was about 30%. So 3 out of 10 children accessing treatment. So a pretty low level of coverage. The thing about Cameroon, and just to kind of emphasise here, is that there was only probably in 2 of the districts was there NGO support. So when I talk about NGO support, as you know, ACF supports the treatment of CMAM in different countries around the world. And in the districts, in the countries in which it works, it will support specific districts. It won't support generally many districts across the whole country. It will support maybe 5 or 6 districts within a kind of high priority area. So the extreme north was seen as the highest priority area. And so that's where donors are willing to fund programs, basically. And so a lot of these districts are supported by NGOs. And when I say supported, I mean the NGOs are there to provide technical support, to train centre staff, to ship things around the district, to provide logistical support. And so generally the programs are stronger in those districts. But in all the rest of the regions, there was no NGO support. Yeah.
Why did UNICEF send you to regions where they provided no support?
UNICEF are, but not NGOs.
Okay.
Sorry, so yeah, I should clarify. So UNICEF does provide support, but it's a very, very light support. It just basically supplies the product, and it conducts, or it funds the salaries of a couple of kind of regional level guys who then implement the programs on the ground. But it's a much, much lighter support that you would see in a program. So in ACF, for example, work in 2 districts up here, and they've been there for a year or so, and they have a kind of a mandate to improve community uptake and improve the quality of the programme. And it's, you can see that those areas are they have much higher performance standards. But in the rest of the districts, it's just UNICEF that's supporting, but at a kind of national level, just kind of light touch. So they're supporting 68 districts across the area, but it's quite a light touch. So yeah, I hope that's clear. So yes, pretty low coverage results. Not entirely unexpected, but hopefully enough to kind of galvanise national actors into action, for the government to take notice and for UNICEF to take notice, and maybe the donors as well. So it's often coverage surveys are used as kind of advocacy tools to generate more funding and just to raise awareness. The reasons that kind of came, so as I said, when we found non-covered cases or children that weren't in the programme at the time, the surveys did questionnaires. They did a quick questionnaire to try to understand what the main reason was for a child not being in the programme, or what we call reasons for non-attendance. And we then ranked these reasons like this. And the first reason, or the first two reasons, relate to a lack of information. So the first reason that came across most strongly was that I didn't know that there was a programme available to treat acute malnutrition. And the second one being, I didn't know that my child was sick. And those two, obviously, they made up the vast majority of responses. And they really kind of clearly illustrate why you can't just put a CMAM programme in place in a health centre and expect people to come. You need to do community. Going back to the kind of first slide that I presented at the beginning, community outreach is so important. Just to ensure that there's regular measurement of children under 5, ensuring that tapes are kind of in the communities and the most furthest, most distant communities, and that the outreach workers are trying to recruit cases into the programme. And it's so important to do that. If in this case there was a certain amount of community outreach going on, but it's been kind of sidelined. I guess the priority for them is just to put the treatment in place in the centres, and there were big gaps in community outreach. So those are the kind of the biggest reasons behind the kind of very low coverage that we saw. And this isn't rare. This happens across most of the surveys that I do. These are the first reasons that come up, but hopefully they help to improve a bit the advocacy of trying to get people to realise just how important it is to do sensitisations and screening. So going house to house, screening every child in rural communities. But the other thing to add is as well that knowledge about a child being sick or knowledge about a child being malnourished is also quite low, and that's I suppose it's quite, unless you realise or unless you know about malnutrition, it's not easy to kind of recognise it in a child, and that is again kind of coming back to the fact that sensitising, that showing people, or helping people understand that a child with diarrhoea or a child who is very kind of listless and non-responsive is likely to be malnourished, and so they should go to a health centre to have them checked out, rather than just feed him more food or feed him more water from home, which might be contaminated and might make the situation worse and worse and worse. So, anyway, a snapshot of results from Cameroon. Just to kind of some final reflections. What did the survey show? There were pockets of high coverage, but overall coverage was low. It was quite clear that the community outreach is very poor, and also actually the presence of NGOs doesn't necessarily lead to high coverage. So that was something that could be investigated further. But what did I learn? And this is really like something that struck me. I'm so used to going to regions and countries where acute malnutrition is kind of highlighted as a big problem, and that's why ACF is there, that's why NGOs are there supporting. But this, I always perceived Cameroon to be a kind of middle-income African country. They'd had a stable government for about 20 years, and I thought the coverage would be a little bit lower because I just hadn't heard about Cameroon in the news. It hadn't flashed up, it hadn't been. We had had programs there, but on quite a small scale for many years. But I saw the sickest children who I'd ever seen. I saw in these very rural, untouched communities in Cameroon, and very lush, in very kind of lush green areas where there was lots of food, there was lots of access to water. I saw some of the sickest children I'd ever seen. So it was a real shock and a kind of reminder to me that acute malnutrition is an everyday emergency in many of these countries. And obviously also the government resources, so the Cameroonian government resources are often very limited, or nearly always very, very limited. And so that's why NGO support is so important. And just also the heroes are numerous, so we always focus a little bit on Hawa, the story about Hawa, which is amazing. I'm not putting that down, but I saw when I met probably 10 Hawas when I was travelling around, and they do exist in these areas. They're just very, very limited on resources, they're very limited on support, and so I think it's just important to remember that yeah, there are lots of people who care, definitely. It's just that they're not empowered or don't have the resources to tackle acute malnutrition. So we're running out of time, but that was Cameroon. Does anyone have any burning questions about Cameroon?
Just in terms of when you get back,
Yeah.
how is that, probably not going to know, but how is that data used? Do you then write recommendations for how to increase coverage? Or?
Sure, yeah. Well, I wrote a report, which is still being signed off by the donor, by the clients. But I write a report with recommendations. They then use the data and use the information I present. I make lots of charts and lots of graphs and things which kind of summarise the results. But yeah, they then normally at the end of the process we have a workshop with the kind of key players, and we have an action planning workshop, and we look at individual problems, and then they set out an action plan, which in theory is then taken on board by them and followed through. But that's kind of outside of my control. I've done my work, and then I go and say, that's not good. Sorry, so I'll just zip through Bangladesh. Bangladesh, I was there last month. It's very nice. I had been there a year previously, or 8 months previously. But this time I was asked to do a coverage assessment in the host community in Teknaf and Ukia, which are two upsillas in the region of Bangladesh, the region of Cox's Bazar, which is the southernmost region of Bangladesh, stuck right down in the bottom. So, as I'm sure all of you know now, that Cox's Bazar is where the action is. There's a massive amount of funding going to primarily the refugee response, but also to the host community as well. So part of the, Jamie might be able to help me on this, but part of the agreement is that 30% of funding that goes for refugees, or 30% of that funding should go to the host community. That's part of the government's kind of rules for allowing. Sorry. That's part of the government's rules for allowing this massive response to happen, is that yes, you can respond, but don't forget about the host communities in this already quite poor region. Yes, this focuses primarily on the host communities, so basically the Bangla population in and around the camps in Ukia and Teknaf. There's a population of about 350,000. 2 surveys have been completed in previous years, in 2015 and 2017. And it indicates a really strong coverage. So coverage was 70% based on the 2 surveys previously, which is very, very good, considering that it's mostly paddy fields and rickety and bumpy roads and rickshaws and things. So, and that is kind of on the basis of this really strong community outreach approach, where they have community nutrition workers based in the facilities, and then this army of community nutrition volunteers who are responsible for a certain portion of villages, so kind of specific parts of villages to do sensitizations and screenings. So they're out there talking to mothers, they're out there measuring children every day. And yes, they're called volunteers, but they are paid as well. So they are, it's an employment for them, and they're part of the community and supporting their community. And this model has been operating for 7 years in the host communities. So it works well. The previous surveys showed that there was high coverage, and it's all done through local partners. So local NGOs, ACF supports local NGOs to do all of this in collaboration with the government. So, but the big question on my mind, like doing this survey, was how had the Rohingya influx affected the programme in 2017 and 2018 influx. So just a very quick snapshot, some pictures from the Rohingya camps when I was there in August 2018, and this immense population of Rohingyas living in these makeshift camps and established camps just over the border from Myanmar, but in the same districts as the host communities. So nearly 1 million, nearly 900,000 Rohingya refugees suddenly, well, didn't suddenly arrive. There were some there beforehand, but nearly 900,000 arrived to have to kind of live in this area and to somewhat compete for, well, not compete for resources, but there was additional pressure put on all resources to respond to their needs. So, what was the impact on the community? Well, host communities, as I mentioned, are mostly based around paddy fields and also fishing as well. So quite poor rural communities, very much at risk from the regular cyclones that hit the region. And what we set out to do was a squeak investigation. So the squeak survey essentially is a 3-week process where we go through a bit of an analysis of data to start with. We have a big series of discussions and interviews with community and clinic staff. We compile and we triangulate data, so we're kind of constantly trying to find links between the data that we find. We test some theories, and then, based on all of this information, we estimate coverage based on the available information, and then we combine this with a survey at the end, and the results give us a final coverage estimate. So that's like a squeak in one sentence, which is really, really inadequate as well. But that's just a very quick snapshot of the method, how we set out to do it. And I can talk people through the method in more detail later on, or another time. But it took about 3 weeks, suffice to say, and there was a range of different exercises followed. I had a team of about 35 very efficient data collectors. One of the challenges was, this is the whole process, and actually just to emphasise that the people who were participating in this survey were with a programme team. So they were the ACF and their partners, their team members, their programme managers, the guys who were responsible for putting into place the programme. And so the whole process at the beginning is to do with building the team's awareness and understanding about factors affecting coverage. As I said, coverage is always the thing on my mind when I'm in these surveys. So that went through like that. Focus group discussions, measuring children and community with MUAC tapes. Again, the same process or a similar process to what we did in Cameroon. And then this is some of the data that we kind of triangulated and wrote up onto flip charts. So much information. Anyway, we got that. But what did the information show? The information showed that very unfortunately coverage had dropped in both SAM and MAM treatment in the two auxiliaries. So we considered we merged the two auxiliaries into one, or the two districts into one. And unfortunately, yes, SAM and MAM treatment had dropped to, yes, about 60 and 50% for SAM and MAM treatment, respectively. However, there was still very good awareness about the program, but there were multiple impacts of the Rohingya response. And I was going to ask what you thought they were, but I actually showed you the first one by accident. One of the big impacts that came about was the availability of highly paid work in the camps. So, as I mentioned, the whole community outreach component of this program in the host communities is based on this army of CNVs, or this volunteer army. When the Rohingya response came along, suddenly there was a huge amount of demand for work, normally much higher paid work in the camps, which led to a lot of people leaving their roles in the host community and moving to the camps. So unfortunately, there was a big resources gap, human resources gap. What else do we think? Well, the other thing that came up strongly was that there was a huge sale. There was a lot of product being sold in markets. So in the camps, the Rohingya community or the Rohingya communities were being given, literally handed out a lot of nutritional products for their children, potentially not with the relevant amount of kind of sensitization about how to use it, and they don't really have any income generating opportunities, and so they were selling a lot of this product in the markets, unfortunately. So this, we feel, had a number of impacts. It reduced the importance of the product from the eyes of the host community, but it also just led to just confusion, I think. And so a lot of host community people or host community children fell out of the program or defaulted from the program. So we think it had quite a big impact on the coverage. Just going through these, there was also quite a lot of increased accessibility challenges. So, as I'm sure Catherine would agree, the traffic there, like to get to and from the camps, is unbelievable. Like suddenly, the roads, these very, very small roads, have been swamped by buses and trucks, big 4x4s and lorries, transporting stuff to and from the camps. And this has really had an impact on the accessibility of the health centres for the other staff, for the host community, which has been a big problem. And to a certain extent, there's still an ongoing rollout of refugee nutrition programs. So there are refugee communities that don't have access to nutrition programs, and so they go to the host community ones. However, in many cases, they're not aware of them, so that has also affected the coverage of the host community. And so that's that in a nutshell. I think it was a very. I'm still kind of going through the results at the moment, but just the main thing is that the impact of the response, the impact of this huge amount of people arriving from Myanmar has had quite a big impact on the national program that is there already. So yeah, That was the investigation.
Did you expect that?
No, in a word.
Really?
I thought we felt that there had been a small decrease in coverage.
They're not that big.
But not that much, no.
It's quite a lot from that, isn't it?
Yeah, it's unfortunately quite a lot. But we did put in place a nice action plan at the end, which I have confidence will actually be acted upon, because that's what they're there for. And there's a huge army of ACF workers who can do it, I hope. Sorry, so I'm conscious we're now well over time. Just some really quick learnings, and I know I can't go through the squeak method in great detail, but there are some small things that I picked up. In Cameroon, for example, training large teams. So a huge team of 80 people that we had to train over, and we only had 2 days to do it. What's come through to me so clearly through training, certainly surveyor teams, is that you only cover the information that you need to train them on. Often it's easy to include far too much information, like I have done in this presentation. But often I include far too much information, which people zone out on. And so only include the information that you need them to know. And it kind of goes without saying, you communicate the message, you repeat it, and then you practice and practice and practice. And so practice by getting scenarios and getting people to do exercises and things and discuss different things is really important. And I got some good learnings from that. I've mentioned it already, but the tablets and Kobo Collect have really revolutionised data collection in the last few years. And they were absolute lifesavers for me during Cameroon. I could check the results every evening from my hotel room. And WhatsApp, yeah, this is something for which, yeah, I'm not that used to do it well. I use it quite a lot, but anyway, it's something you did at WhatsApp. Setting up these massive WhatsApp groups was a great way to supervise people. So you could like send tips and clarifications over WhatsApp every evening, and every single surveyor was on this immense WhatsApp group. It now also means I have so many friends in Cameroon that you just can't imagine. So yeah, WhatsApp is a very, very useful device for supervising teams these days, especially as mobile network and internet connection or data is pretty much across large parts of Asia and Africa. It's very good on the whole, and so you can communicate with you. The other thing about qualitative data collection, so this is really from Bangladesh, and this is it's qualitative data collection, so doing a really good focus group discussion, doing a really good interview with an individual, trying to create a calm environment is not something I find that comes intuitively. It takes practice and supervision. I think I myself, I'm still learning. Lenka, who is in Haiti at the moment, is like the proper expert on qualitative stuff. That's what she excels at. So hopefully she'll appear at some point and give us training on that. But it's a very handy. It's a very good thing to do, very good thing to practice. And in Bangladesh especially, where people are quite used to following very kind of set guidance, it was quite hard to get people to really embrace qualitative data collection. Some people are stronger, other people are weaker. And it's really important though that they understand questions that they're asking, and there's scenarios and role plays used during the training. So I'm really sorry, this has been like a death by PowerPoint lunch and learning. I'm very happy to share the PowerPoint with anyone who wants to read it in slow time, or if you want to have a discussion, but I realised there wasn't much interaction. I broke my number one rule of training after all these experiences of just lecturing you for an hour, so I'm really sorry about that. I hope that no one fell asleep, but thank you very much. These are three little chaps we met in a village in Bangladesh. The most serious little dogs you can imagine. They were part of a school. It was a school thing, I think, but they were quite funny. Clarification. Please, yeah.
So in the spirit of like Learning Week,
Yes.
this is obviously the first time you've done a squeak. It's basically national level.
A coverage survey. Yeah.
Like, I mean, it's essentially national level.
Yeah.
I guess my question is a bit mean. Is there anything like that you would do differently next time with your sampling strategy or how you approached it that you've learned that you could share?
Do you know what? I think I did a great job on this one. No, there's always stuff. To be honest, the only thing is the client hasn't actually signed off the report yet. I really want to get their kind of feedback and learnings. But there are small changes I would make to the data collection. But in terms of the actual method, it was done as well as we could have done it. If we'd been able to have maps with villages marked and being able to get a much more geographically representative selection of villages, that would have been ideal. But that's a pipe dream, really.
Yeah.
But it's, well, from this perspective, I think the only thing that can be said about learning is just having more people involved who have can really see the impact of the survey. So the result, or hopefully the report from Cameroon will be finalised in 2019 at some point, and it might end up in the hands of a donor, but by which point it will be 6 months old. And I think it's such an important thing to present, and the results from it are so kind of clear and kind of shocking that often, and this is what I found in my last coverage survey in Bangladesh, people just want to kind of bury the results. They don't want to show it to their donors because it just shows that the programme is quite weak in places. But it's a learning document, it's a learning process, and so if we can get more people involved.
More program stuff.
More program stuff, absolutely, but also more of the kind of decision makers.
Yeah.
How many people were involved in the data collection? How many researchers were there?
In Cameroon,
Yeah.
about 8.
Also in Bangladesh.
About 80 in Cameroon, because we needed to cover a big area. In Bangladesh, we had about 35, but it was too big, really. We could have done 20, 24 maybe. But there were just lots of extra people.
We had a lot of stuff.
They have a lot of staff in Bangladesh. So yeah, about 24.
These kind of surveys are used to inform where an NGO would work. Were they always about programs being in place?
No, these are normally to assess programs that are already in place. So you can only do these surveys where there is an existing CMAN program, because you're measuring the performance of that program.
But like if it was a big district, for example, and like there was like one NGO operating in it, would someone do like a coverage survey to say like, oh yeah, other people need to come and like work in this area too?
Yeah, you could do that on the kind of national scale, yeah. I mean, if you get very, very low coverage areas, you could be like, okay, we need to send ACF to that area to increase coverage because there's very poor performance there. But the main method used is the main survey that is called that is used to measure the kind of severity of malnutrition in a district or in a particular area is a SMART survey, or a kind of nutritional situation survey, which assesses the prevalence of malnutrition. So where is malnutrition most severe in country? And you can kind of pinpoint the areas, and then on the basis of that, they normally use that to send resources to alert and put in place emergency operations. And breathe.